start. I think I was on my schedule. I didn't make it sure what to show on the screen, but first 15 was going to be Calgary, next 15 Kelowna, next 15 Saskatchewan, and then the last 10 minutes I just reserved for flex time or discussion or what have you. So, Ms. Calgary, our first day is Rob.
All right, I'll get started then. So can everyone see my screen? Awesome. Okay, so nice to meet everyone. My name's Rob. I'm a general internal medicine fellow in Calgary. I did my core training down in Edmonton and or up in Edmonton. And I'm relatively new to the POCUS world. I've seen a lot of you on Twitter, and actually I've met some of you in person, which is nice, but thanks for having me. I guess this is my first time presenting with you, and I look forward to a good career in POCUS. So today I'm going to be presenting a case report and some information around it about left atrial compression, a really interesting case we saw just a couple weeks ago. This lovely patient who came in quite ill. And we're going to talk about sort of the sonographic pieces to this patient's puzzle. So I have no disclosures, no one pays me, just Alberta Health Services. We had a pretty normal presentation with this patient, 87 years old, relatively elderly, lives in Calgary. And she comes in with primarily the presenting complaint is 2 days of chest discomfort and palpitations. And that's on a subacute course of decline over the last several months. And that was largely attributed to recurrent C. diff. And she'd become deconditioned, short of breath, and more or less bedbound actually. And so EMS gets there to her long-term care home. She's found to be quite hypotensive, blood pressure 70/40. She's in what seems to be rapid atrial fibrillation. And she's brought to the hospital, of course. She spontaneously converts in the emergency department. I don't actually have an ECG even of atrial fibrillation, but that was on rhythm strips. And she has a medical history that also is pretty comorbid. She has decompensated NASH cirrhosis, prior GI bleeds, recurrent ascites, but not quite so bad, heart failure with preserved ejection fractions, and several admissions for volume overload over the last several years. Coronary artery disease with an NSTEMI in 2012, and then the CKD, just very mild. But the C. diff infections are another notable piece. So her labs aren't too interesting, to be honest. I just highlighted some red, but really her BNP is mildly elevated, NT-pro at 549. Her creatinine is actually near baseline, little bit anemic, little bit thrombocytopenic, not different than her normal. And she had a mild trope pump that just downtrended, wasn't rechecked. Physically examined, pretty benign too, to be totally honest. Cardiovascular exam and respiratory exam kind of present a bit of a heart failure picture. And she's on 3 liters. She does have ascites pretty clearly, but that's not too different for her. Here's her ECG, and to save you time, it's also not that interesting. I guess everything's interesting, but in this case, it's pretty benign. Bit of sinus tachycardia, low voltages, left anterior fascicular block, rate is 115, I think. Intervals, all normal. Here's a chest x-ray, more benign pieces of her puzzle. We have what was called as bilateral lower lobe opacities, possibly suggestive of a pneumonia. This is her. Again, for brevity's sake, I'm just gonna move forward, but it's pretty normal looking, little curvy. So well score is 3, not too exciting. A dimer is done. It's actually below the cutoff and age adjusted cutoff. So bedside ultrasound time. And I'm just going to be presenting some cardiac pictures today to keep things quick and short, but of course a whole body ultrasound would be definitely indicated. So here's our first picture. We have a long axis and a short axis, and I'm wondering if anyone would like to hazard as to what they see.
There's not much left atrium there.
Yeah. There truly isn't much left atrium there. Yeah, anyone else have sort of comments about what's interesting about it? Anything at all? it really is just that left atrial piece that we're mostly interested in, as per my presentation title.
Something that's a little unusual, that's in, where it's something thoracic aorta is normally, or maybe just beside it, but what's a little bit strange there in that far field on the image left.
Yeah. So it really is largely the left atrial compression that we're sort of interested in and honing in on. And yeah, there's that sort of like hypoechoic area behind it. It seems like it's possibly circumscribed, maybe some like gas bubbles in it and mobile pieces, but we're really not sure. Like that's all we see, and the short isn't too interesting. So some more pictures, apical 4 and 5. Anyone interested in sort of what they see? Sorry, these pictures aren't quite as high quality. I'm working on my acquisition skills. Sorry, guys. Crickets. I guess it's a little harder to interpret with the quality of the pictures.
Yeah, again,
But
it
you
just
can
looks like
definitely
there's
see
something compressing that left atrium there that looks to be external to the heart, causing compression rather than something within the left atrium from these views.
totally, and we agree with that as well. The patient did have an echocardiogram that said it was like a 7/10 mass compressing the left atrium, extrinsic. So we'll move on. Differential for a mass compressing the left atrium, we'll talk about retrocardiac masses. So I actually didn't find any resource online that was sort of like the comprehensive list. There's not an up-to-date article on this. Really, I sort of put this together through various case reports, any literature I could find, and also the up-to-date article on posterior mediastinal masses. And what comes up a lot is hiatal hernia. Of course, your sort of mediastinal masses with lymphoma, neurogenic tumors, particularly schwannomas seem quite common, meningoceles from the spinal column, and then pancreatic pseudocysts, abscesses, hematomas, various cancers and adjacent structures, aortic aneurysms came up quite a lot. Both ascending and descending are possible, and those can also compress the pulmonary veins, it seems. Your PHEOs, and there was a really cool case report with this esophageal lymphangioma where this patient came in asymptomatic. I forget why they even came in at all, but they had this massive mass compressing the left atrium, and they opted for no treatment after biopsying a lymphangioma, just a benign growth, and then any spinal deformities too. So I'm curious if anyone sort of hazards a guess as to how we could delineate this mass at the bedside. Anyone?
Anyone, what do you guys think? Liam and crew, what do you guys think?
I'm not 100% sure what you mean by how would we delineate the mass, if you mean by specific installation or otherwise, but otherwise, just going back to the basics, I guess, in terms of history and physical exam, try and judge this by the company of peaks in a sense. So is there any history of weight loss, fever, or chills, or anything that could guide you towards it? Is there any GI symptoms, any pain, all sorts of things like that. But yeah, all this mentioned there, if you think gastric accident, something.
Yeah.
If you were in an
Totally,
ICU, you could just pop down a TE probe. That would be the easiest way to get a good look at the left atrium or whatever it's beside it.
And also, you want to look
Yeah.
at the wall, right? Like if they actually have lobar collapse, like you might have a window to esophagus, but you can also look at their neck as well, like just lateral to the trachea, like left lateral to the trachea, which is taking at the kind of the femoral area. Also,
Yeah.
this has a lot of actual active vascular flow. So
Yeah. All really reasonable ideas. I see some people sort of got to something, yeah, in the chat as well. Get them to drink something. So like, I guess asking the question like, is this something of GI origin? And then, yeah, of course, like color, maybe a contrast enhanced ultrasound if you have the skills and resources. And so that's just what we did. This has been something that's been reported before. This is just one case report of exactly that, oral contrast echocardiography, using something pretty run of the mill. I don't know about you guys, but sort of my mildly guilty pleasure over the pandemic period has been increasing my bubbly consumption. And that's just what we did. So here's a picture. And you can see some increased hyperechoic spots with consumption of said beverage, sort of in that mass area. There's my mouse, sort of pointing out the key highlight. It gets really exciting with like a pop at one point. I was like showing this picture de-identified to some like family, and they said they didn't see anything, but I think it's pretty exciting. So now to continue the case, what we've essentially proven is that this is something of GI origin, esophagus, gastric, something where the fluid goes down towards, and we can see it on ultrasound. And that's literally what you see here on CT scan. Here is the hiatal hernia, what the diagnosis was. So it's a large hiatal hernia that's compressing the left atrium. You can see it in this picture, and here it is in these cuts as well, compressing the heart. Pretty cool. So to continue the case, she was unfortunately diagnosed with a C. diff recurrence. Her medical team thought that perhaps, given her presentation, thoracic surgery could assess for the hiatal hernia. And I'll get as to the physiology behind why that was the case. But they declined operative management with how sick she was. And frankly, she was not interested in that either. In fact, she wasn't interested in much but symptomatic care. She had really struggled over the last month. So she opted for symptomatic management in the end and was eventually transferred back to her long-term care facility. I had some thoughts about her case though. One is sort of the question of sort of exercise capacity and left atrial compression. And in this study where they collected patients with obviously large hiatal hernias, given that they were undergoing laparoscopic repair, 23 out of 30 of these patients had left atrial compression on CT scan, not ultrasound. I don't know the question of ultrasound in that case. But interestingly, the most predictive parameter postoperatively for improved exercise capacity, which is one of their indications for surgery, was left atrial diameter. So it's an interesting finding sonographically and on CT scan. Another thing I thought of was, why did she come in AFib in the first place? And actually, there are lots of, a decent number of case reports of patients who have left atrial compression, the cause of the compression fixed, and atrial fibrillation resolved because of that factor. So perhaps her left atrial compression was why she developed atrial fibrillation, and then why she presented. Was this left atrial diameter post-op or the change in diameter post-op? It was the change in diameter post-op. So I think the change in diameter post-op that they measured was like the mean was 11 millimeters, I believe, in that study.
And Rob, do you have any color images, like color Doppler images with that image set, or no?
No, sorry, it's a little difficult to hear. Did you say, did we put color on that?
Color. I'm just curious if there was evidence of flow obstruction, like a flow acceleration in the atrium.
No, I don't have that. No.
Okay, I'm curious.
Thanks. And then I guess just to finish off, you asked the question of like how else could fixing this patient with like a thoracic surgery is one way to look at her case, but perhaps conservatively, especially in context of her overall care, you can think like maybe reduce compression with decreasing the amount of content in her stomach, frequent small meals, upright after meals, conservative stuff like that, decreasing her intra-abdominal pressure. And then also getting at her preload dependence. You wonder if she had poor LV filling because of this left atrial contraction, and she has known heart failure with preserved ejection fraction, high LVEDP physiologically, and then she develops atrial fibrillation, comes in hypotensive. It seems kind of obvious. So in her case, good management of her preload and her volume status is absolutely important to keep her out of hospital in the future. We didn't really have that involvement with her, but just some thoughts for maybe patients that come across your doorstep. So to close off, sorry for taking a little longer than anticipated, but hiatal hernias are common causes of left atrial compression. It's certainly on the differential, and you might be able to differentiate a gastric esophageal GI pathology with oral echo contrast. Here are my resources, and thanks.
Actually, right on time, Rob. Your time's perfect.
Rob, that was great. Thanks. Interesting case. I was wondering if you did any thoracic ultrasound, because if you diagnose, you can see the stomach bubble above the diaphragm. It might be an interesting way, again, of confirming a hiatal hernia.
So we did not do any on her. It's definitely a good question. The truth is, I see my internet connection is unstable. I'll keep talking, but so we kind of did a limited assessment on her because truthfully, she was having a lot done to her. In fact, Dr. Desi can corroborate, just to keep her involved, her stay in her room, she used to sing with her. So we were singing I've Been Working on the Railroad with her, and she like it was quite an event just to get these pictures in the first place. So I really wanted to take more pictures, but we were really limited by her just tolerating us being in the room. She eventually warmed up to us, and to be totally honest, she is stoked that we're presenting her case right now. Like she's really excited that sort of her information could get out there. But no, sorry, I don't have any other pictures.
But I think her CT scan would give you an idea whether you could actually see that hernia laterally or posteriorly. It looked quite central. I could be wrong. I don't know that, it may have been occluded by intervening lung.
Yeah. Yeah, hard to.
Yeah.
Hard to...
And it's a non-contrast CT, right?
Yeah, I know. I've just been, I've had learners come to me being like, oh, there's some sort of lung abscess. What's going on here? And you go look, and it's actually like you see, stomach rugae, and you see like the NG tube floating in the abscess. So sometimes it shows up really nicely on thoracic ultrasound.
Yeah, totally agree. But I think in her case, I suspect you might not see a ton.
Yeah. Interesting. All right, I guess I'm up.
Yeah.
So for those of you that don't know me, my name's Matt. I'm a ICU doc and emerge doc based out of Kelowna. And as Vic mentioned, I actually just got formally hired into their ICU group. So I'm pretty happy about that as well, and honored to join their group. So this is a case I had a little bit ago. And I guess just before I get into it, the other kind of news piece for the Kelowna site is that we just started a critical care ultrasound rotation aimed at senior residents that are keen and willing from across different specialties. And so we just had our first resident rotate through, and I think it was a really big success. And so I hope that in the future we'll have further residents rotating through, and we can continue to build the rotation up. So that's kind of the newsworthy end from our end. And then, so then I'll get into this case, which I thought was a pretty neat case. So this involves transcranial Doppler. And so I'll go over kind of some of the basics about that and kind of how we applied it in this case. So it's a 30-year-old who's involved in a motor vehicle accident, essentially had isolated severe traumatic brain injury, presented with a very low GCS, vented, pan scanned, but ultimately just showed just had severe traumatic brain injury. And I don't know how it works at other centers, but here we often don't have ICP monitors in place. And often, without getting into a journal club on this study, but this Chestnut or Best Trip study from 2012, New England Journal of Medicine, which compared outcomes with ICP monitoring versus no ICP monitoring, showed really no appreciable difference And sometimes it gets quoted as for why the neurosurgeon doesn't want to bother putting in an ICP monitor. And there's many flaws with this study, and we could discuss it, but I think most intensivists really like having an ICP monitor because it's often very difficult to follow these patients clinically. And often we're left kind of feeling like we're flying blind without an ICP monitor. But instead, this is a case where I was able to kind of not fly as blind by application of just point of care TCD monitoring. So this was his initial CT head, just a kind of one coronal slice. It was red. There's a few little areas of punctate hemorrhage, but otherwise was essentially normal, no large subdural or intraparenchymal or epidural hematoma or subarachnoid blood. There's a few kind of foci of intraparenchymal blood, but kind of consistent with kind of diffuse axonal injury. And so he was brought to the ICU and managed as we manage any other, severely injured brain, with good supportive care and avoidance of secondary insults. But I decided that because we didn't have an ICP monitor and he was quite, and he was so, his GCS was less than 8, so definitely qualified him as a severe traumatic brain injury, that I'd follow him daily with kind of daily TCDs to monitor his ICP, which I'll get into. And so if anybody wants 2 good papers to get started on this, one is just recently, and you can see Katie Whisker's name on there, who's on the call. And Vincent Lau is the lead author on both of these. I'm not sure if he's on the call or not. But first one came out in Chest, Better with Ultrasound series, which a lot of you are familiar with and have published in. Approach to Transcranial Doppler. And another one is a few years ago, Point of Care Doppler by intensivists. They're both really good resources to just get started with this. It's really, I honestly, once you've done it a few times or practiced with it, I do think it's a very, generally speaking, quite an easy technique to get the hang of and to apply. There's a little bit of training and a little bit of fluency with Doppler. So if you've got fluency with Doppler from cardiac, I think it's actually even an easier skill to then learn to do TCD. And every now and then, just like with echocardiography, 10-15% of the time there'll be just awful windows or won't be windows, and that happens in TCD. But usually, most patients you can get a good window. And so the technique we typically use, there are other windows, or either occiput, there's transorbital to interrogate other branches of the circle of Willis. But the most common one that we use, because it's the most easily interrogatable, and also we care about as intensivists more of the global picture of what's going on intracerebrally. So it's the transtemporal window. So you place the probe on the terion, which is the thinnest part of the skull, kind of as all the different skull bones kind of converge. Pro marker goes facing forward, and you can see in kind of diagram A, and this is from the Better with Ultrasound paper. And then you're looking for the contralateral temporal bone here. And then you're looking for some midline structures, the midbrain, either this Mickey Mouse structure, the cerebral peduncles, or the slit-like structure here, the third ventricle. And that kind of defines midline. And then once you put color on, which I'll show, then you know that the middle cerebral artery is going to be just interior to that structure at about 4 to 6 centimeters of depth. So this is just showing that. So again, this is the anatomy. So classic picture of the circle of Willis with your MCA. And this is what we're most commonly going to be interrogating, this MCA kind of going upwards. And then on the screen right, you just see the color Doppler showing the red. So red towards the probe, near field, and very good Doppler alignment to capture that. And then down below, you see kind of the classic waveform that you get with this peak systolic velocity, and then just the slow stepwise decline to your end diastolic velocity before the next cardiac cycle starts again. So generally this is just a kind of normal all the way to cerebral circulatory arrest in terms of what you're looking for. And so up top here, you have your normal, like in the last picture, this normal peak systolic velocity, and then just this slow stepwise decline. And as your ICP increases, your intracerebral pressure increases, you actually start to get diastolic blunting, where your flow in diastole becomes truncated, and you don't have as much flow. And so you have a steeper decline all the way into here. And in C, you're actually having even diastolic flow reversal into larger diastolic flow reversal. And then at the end here, you're basically having little blips of systolic flow until there's no flow at all. And the patient would be, neurologically brain dead. So, the good thing about TCD is that you don't really need to know these formulas really, because so much information is just in the waveform itself. So if the waveform looks normal like this, then their ICP is likely normal. And if their waveform is abnormal with this diastolic blunting or reversal, then that their ICP is going to be elevated. But if you want to, we like numbers and we like regression formulas. So we can calculate a pulsatility index, which is your peak systolic velocity minus your end diastolic velocity over your mean velocity. And from there, there's this regression formula to estimate your ICP here, which I kind of simplify in my head at the bedside is just 11 times the PI. And if you're using your calcs on your machine and you have a TCD preset, your pulsatility index will often just spit out automatically. So then I just kind of quickly in my head multiply it by 11 to get a rough idea of the ICP. So anything kind of approaching 2 is going to be abnormal. So this was his initial TCD. And unlike echo, the 2D images are really unexciting, but just for educational purposes. So this is his contralateral temporal bone. And in here, not the best image, but there is the midbrain or cerebral peduncles right here, peduncles, sorry. And then with color Doppler, this structure here at about 4 or 5 centimeters of depth is the middle cerebral artery. And the more midline you are, it's more going to be M1, M2, M3 if you want to get into the specific area of the middle cerebral artery. And this was his initial waveform on day 1. So actually quite reassuring. So, so this was normal. So on day 1, he's got a nice stepwise decline. There's no diastolic blunting. And this would give you a normal pulsatility index and normal ICP. So we were quite, at this point I was reassured. So continuing just, good old fashioned critical care supportive management and making sure that there's no episodes of hypotension, normal glucose, all the other normal oxygen saturation, all the other good supportive care things that we were doing. But then on day 3, this happened. So this was just during my morning, this is essentially pre-rounds, even before we met. I was kind of quickly doing my my walk around the unit, and because ultrasound could kind of sometimes disrupt the flow of rounds, I often, if there's people that I specifically want to get more advanced studies on myself, then I'll kind of go and do it myself a lot of the times, even before we run the board. So I found this. And so, yeah, you could say that the pulsatility index reported there is only 1.8. So the ICP is really not sky high, but the morphology, which is why I love TCD, is so strikingly different. And so you see now that, marked diastolic blunting with this, very large peak systolic velocity, but now their end diastolic velocity is much more mitigated. And so just, I repeated it just to make sure that this was a real finding, but this prompted me. So that at this point, there's no kind of clinical change reported by the nurses. There's no focal kind of unilateral finding or focal neurological deficit. But again, realizing that following these patients clinically is difficult because, you're having to stop sedation and you're having to, give it enough time. And sometimes it can be quite logistically challenging. And so this was just a quick, non-invasive way that really alerted me that there might be something going on. So I decided to send him for an urgent repeat CT scan to see what was going on. He actually had one on day 2 as well, which had no significant change. And so this was day 3, and I wouldn't have normally repeated the CT scan at this point, but decided to send him for an urgent CT scan. And then this is what we saw. So he's developed a huge new right frontal intraparenchymal hematoma with even a little bit of midline shift. And so this was obviously a very drastic change from just really the diffuse axonal injury and kind of small punctate hemorrhages that we had seen before. And so this is from day 1 on screen right, and screen left is from day 3. So just to show you
Hey Matt, it's Vic. I just had a question. Was
Yeah.
the TCD the same or similar on both sides, or did you just do one side?
I just did one side. It shouldn't. If you're using TCD to interrogate ICP, it really should reflect the global state of the brain and not. There might be minor differences, I'm sure, just because of the intraparenchymal hematomas on the one side, but it should really be similar on both sides. So unless you're, if you're getting into midline shift and you want to confirm and kind of do both sides, I think it's helpful. But or if you're doing vasospasm, sometimes it might help. But I think for ICP monitoring, I think doing just one side is sufficient. And in a busy ICU, I often, and this was enough for me to act on and get this. So I just did the one side, but that's a good question. And then so unfortunately, so I obviously involved our neurosurgeons again, and unfortunately did not feel that that this was an operable event, and they thought that this represented a catastrophic evolution of his traumatic brain injury. And so in discussion with the family and his previous goals of care, we elected at this point to not offer any operative intervention or decompressive craniectomy or evacuation of that hematoma, and instead, we eventually just transitioned to comfort measures and withdrawal of life-sustaining measures. But and then after we had made that decision, the family definitely expressed interest in organ donation. And so at this point, we were going down the DCD route. But again, the next day I came in and I just to see if there was any difference in seeing how things were evolving, I decided to do another TCD. And so this was the final TCD I got on day 4. And so here you can see that this is really approaching cerebral circulatory arrest here. And you can see obviously the diastolic flow reversal and these pretty feeble blips of systolic flow. And then the prominent diastolic flow reversal. And so because I saw this, I thought there was a very high chance that this patient would progress to neurological brain death. And so we actually switched gears and ended up going down an NDD route. And he was ultimately declared formally NDD and went on to donate a lot of organs to save a lot of lives. So this case just shows for me the utility of using TCD as a bedside point of care monitoring tool for ICP, and it has wide applicability not just in traumatic brain injury, but any neurocritical care patient. And there's lots of other utilities for TCD, whether monitoring for vasospasm and subarachnoid hemorrhage. I didn't specifically do it here, but we could have also looked for midline shift. As well, again, using those midline structures as your baseline, which should be equidistant from either temporal bone. And so I really like using this technique. I feel like it's very quick once you get the hang of it, and I think it's a really great monitoring tool when you don't have, in particular, an ICP device or an EVD. Happy to take any questions.
That's a great case. Excuse me. A great case, Matt. We face similar challenges in Saskatoon sometimes with persuading our colleagues to get those monitors in, and I agree that it does really help us with management. Have you managed to get any buy-in from the neurosurgeons about either acting on findings being seen at the bedside, or even potentially modifying practice around ICP monitors if you have enough cases where ultrasound is showing that there's issues with ICP that aren't being revealed clinically?
Yeah, we have a couple of I feel like the ICP is mostly, I feel like some of our more seasoned, experienced set in their way neurosurgeons are less keen on ultrasound and less keen on invasive ICP monitors. We have a couple of newer neurosurgeons here that are much more aggressive in terms of putting ICP monitors, and are actually really interested and keen on hearing about what we're finding on TCDs. So in particular, we've had a few subarachnoid patients where every day they want to know, hey, what is their mean MCA velocity? I'm curious And sometimes it's dictated, whether or not we're, sending people to the ward from the ICU or whether they're staying a few days. Because I've picked up a few cases of kind of mild vasospasm and some of our subarachnoid patients that we just kind of keep them in the ICU for closer monitoring for an extra couple of days before it kind of we document it that it's resolving. And our neurosurgeon, a few of our neurosurgeons are really keen and buy in and are becoming quite involved about it, and they want to see the images and they want to, which is kind of fun to have that collaboration with them on that front.
I can speak to some experience because I brought in TCDs in the neuro unit in Edmonton about 18 years ago. Initially, it took some convincing of the neurosurgeons, but we do it standard in all our subarachnoids. I think with ICP, if you look at the literature carefully, and there's been a recent very good review, it's good. And I use the PIs, but no one, still non-invasive techniques still give you a plus or minus 12 millimeter mercury or centimeter H2O error. So it's, I think, better for following. You can't overcall it, but I use it. Where I did use it last week, where I think it's very important, is there was a carotid dissection TBI in our unit. And so a quick look at the MCA velocities reassures you that they haven't thrown an embolus off. And emboli monitoring after the dissections, I do standard until they get fixed. The other important thing, you can prognosticate with TCDs. So there's a big French cohort, it's very large, that demonstrates, and we rarely see this, but if the MCA velocities are like less than 35, I think was a cutoff, their prognosis is horrible, but we rarely see that. So I think it's great. It's good to push to, it took a year to convince our neurosurgeons years ago in subarachnoid. The other time I think it's very useful is I've had people come in with hydro, they don't want to put in a drain, they get more headaches, and the PI is very useful if the hydro progresses, and it's if it raises with more headaches and hydrocephalus, then I push the neurosurgeons to stick in drains.
Thanks for those comments, Jim. Thanks.
That was a fantastic discussion, and we're also we're starting to use some more TCD with optic nerve sheath just for liver failure, for acute fulminant hepatic failures, because those patients can obviously herniate quite rapidly. So we're going to start a study here probably the next couple of months doing daily actually BID point of care transcranial Doppler with optic nerve sheaths to follow and track.
Brian, I know we're kind of running time here, but do you find the optic nerve sheath diameter adds a whole lot to the TCD?
Well, I've actually had patients who've had elevated ICPs with somewhat normal appearing ICP waveforms like MCA flows, but also grossly elevated optic nerve sheaths. So I suppose I'm a little bit skeptical that we can only use TCD in isolation. Like there's that big meta-analysis, which is I think a couple of years old now, showed that the optic nerve sheath was more sensitive for elevated ICP than TCD. So I guess I'm still a little skeptical until more data comes out about the sensitivity of TCD.
Mm-hmm.
Yeah, I would agree with windows either. You can usually get a window to someone's eyeball, but not necessarily into their skull.
Yeah.
The nuances with TCD is don't confuse flow velocities with, diseases cause increased flow velocities, traumatic brain injury often as compensatory, and it's more nuanced than people think. And I suspect in liver failure, there's going to be an element of that because their pulse pressures are high. And so probably you should do the carotid with ICA with, external carotid with internal to get a Lingard ratio in that, because I suspect there's going to be dynamic changes there.
High output. Yeah, I see what you're saying. That's a good point, Jim. We're running out of time here, and I want to get Paul Olszewski on the line. So
absolutely. Thanks, team.
Yeah, thank you a lot, Matt. That's great.
All right. We're going to switch gears a little bit here. And I'm just going to go to sharing my screen here. All right, so you guys should be able to see a blue PowerPoint. Is that all good? Some thumbs up. So just going to shift gears a little bit, and I've really enjoyed. I think as an emergency physician, I don't get to geek out as much as maybe I'd like to sometimes, especially right now. I don't know if you guys have colleagues in emergency medicine, but at this stage in the pandemic, we're kind of doing two things. We're managing kind of our typical load, but we've become a primary care provider, right? Lots of family physicians don't have their clinics open, access is poor. And so we're seeing high volume, and we're not getting a chance to do as much. So I'm going to use that actually as kind of like my preamble for why the case that we're going to review, which is going to be the second part of my brief presentation here, why it was, I think, an example of kind of something hiding in plain sight that I didn't, that I struggle to kind of, put together, even though it's actually in hindsight reasonably obvious. But I just wanted to give a chance, when we first came up with the idea that we're going to be doing these rounds, I wanted to share with you just my experience with our elective most recently. And I'm really excited about QR codes. So if anybody wants to read the peer-reviewed article related to what we're talking about right now, QSEC is the Clinical Ultrasound Elective and Clerkship. And that'll link you to the Canadian Medical Education Journal. It's you should try this, just a brief write-up of our 2-week elective, but it's basically a specialty agnostic elective. We took 14 trainees this year. Their interests range from pediatrics, anesthesia, EM, family medicine. We've also had other groups like surgery and internal medicine interests in the past. And we do a week of like a boot camp this year because of COVID. Every morning we met online. We would kind of cover content that covers kind of our core curriculum, as well as introducing them to some resuscitative and procedural skills. And then every afternoon, as you can see in this image here, we spent scanning about 15, well, anywhere from 8 to 15 standardized patients. We have 8 teaching machines dedicated, and we have patients coming every afternoon. So they do that for the first week. And then during the second week, they actually go off to their rotation of choice. So if they're interested in family or rural, they'll go to like a rural ER. If they're interested in EM, they join us in the emerge department. And the idea of that is like realistic integration of care. So it's not that they're getting tons of scanning practice. They got that in the first week. And then we do an exam at the end of the first week. We do a practical and a multiple choice exam. But here, this is their opportunity to really integrate it logically into care. And I just wanted to share, there were just, I think we all can agree there's nothing more satisfying than teaching something, some new skill, and then them to be enthusiastic and to kind of go out and learn it. And this was day 2 of a clinical placement in a rural family med EM kind of thing. So this is up in North Battleford, and the trainee sends me this enthusiastic text because she's now managed and seen a patient with COVID. They have butterflies up there. So this is actually kind of ghetto image capture, because this is actually like a camera recording the screen of this patient. But in fact, in this trainee, their presentation was on COVID and POCUS findings in COVID. And then just this satisfaction that they got from the fact that they got to see this patient who had these florid B lines and maybe even some subpleural effusion and some changes that way. And, even though the pictures maybe aren't awesome, it's still quite a satisfying thing to get from your trainee kind of at that training. The other thing to think about, right, is this is post-CARM submission. So like lots of trainees are checked out by this point, but these are the 14 kind of keeners out of, let's say, 100 students at the USask class of 2021, and really committed to it. This was another interesting case. The images are from my library, but this is essentially what they saw. They had this patient who had presented to a sonography gallery and was basically told nothing other than you need to get to the emergency room right away, and kind of comes a little bit disoriented and was found to have bilateral hydro and this massive bladder with some like overflow incontinence, in fact. And this was actually a patient who likely had METs resulting in compression of their spinal cord and cauda equina. So again, just out of these cases that these trainees are putting together and kind of really getting a chance to apply their skill set with us. So it was a really successful week under the guidance of actually Irene and Brian. We had recently kind of done a full review of our curriculum at USask. And I actually kind of then leveraged all of that review and some of the success we've had this year. And our program is purchasing 20 butterfly units for our clerkship program to be distributed throughout the province because one of the things we highlighted, the students highlighted during our review, was access to equipment in services other than EM was not as great as it could be. And so we're going to have these out on like a loaner process, which we're kind of excited about. So we're actually in the process of getting our hands on those machines. So that's kind of exciting. So that's the side there. And again, it's nice to start on a positive note. And then I just wanted to share with you guys, and this is going to be, this is maybe going to seem kind of pretty basic to a lot of you, but I think it just, again, kind of just highlights what we end up kind of sometimes dealing with in EM. And I think you've probably heard, Jack's, what is the saying there? Jack of all trades, master of none. And I certainly kind of feel that way most days. So this was a lady, this was actually a handover patient. She was short of breath. She had kind of, I think the initial physician had kind of developed maybe just a little bit of, in hindsight, maybe premature closure. There was a story of high blood pressure and it's long-standing smoking that recently quit, and some shortness of breath and a non-specific exam, nothing too convincing one way or another. And so she kind of went down the pathway of, suspected acute exacerbation of COPD, tried to do some bronchodilating, check for pneumonia or other causes for the exacerbation. And then that actually kind of came back kind of unsuccessful in the sense of it didn't really, the diagnosis didn't seem to click. There's these bilateral small pleural effusions on X-ray. The patient continued to be quite short of breath. Had this, essentially like a tachycardia with any kind of activity, but was, sitting around 90 to 100 most of the time. And so the handover was kind of, I thought this was probably an AE COPD, but it doesn't look like it is. I've added, these things. I'm going to do a dimer and a BNP, and Paul, can you go POCUS? And that's kind of how sometimes people talk to me in the department, which is fine. I don't mind. They know that I'll often go have a look, and again, I think there's just a good dose of humble pie, because I sometimes think to myself, oh, I'm going to figure this out. So, and then it's not as straightforward as you thought it might be. So I went into this assuming that actually I would encounter probably like a bad LV. I think she had, and I've deliberately left out the B lines, but she had nice smooth pleura. And she had B lines kind of, throughout several lung fields. But I've included here kind of our kind of NED, personal long and short axis views. And again, I think the focus here, or what I'm just hoping to get across, I mean, heart's ticking along. Actually, at this point, she's quite tacky. And I don't know if that's because she's, intimidated by the machine, or whether it's just because like she was just kind of borderline tachycardic. But I felt like she had reasonably good systolic function. I was able to capture good endpoint septal separation. I did notice that she had this small slip of pericardial fluid, but didn't seem to be too significant. On short axis, again, it seemed like she had pretty good function there. We did go on to additional views just because it's kind of like, well, I didn't see what I expected to see. So I should probably kind of take a bigger look here, wondering about, other potential explanations. And maybe that effusion is bigger than I think it is. But on the subcostal view, it looked pretty reasonable. And on her apical 4, again, looked like pretty good looking RV, right? I thought she had probably had TAPSE that was probably near normal, certainly not big and dilated. No sign, to me that there was a significant right-sided component here. And then again, just to kind of put it together, I mean, yeah, she had these small bilateral effusions, and then I thought, okay, this could be just diastolic failure. So I thought, well, if it's diastolic failure, which I hate, by the way, again, what an annoying thing. I thought, okay, well, if she's this overloaded and she's got diastolic failure, at least she'll have like kind of a bigger IVC, an elevated JVP, right? Like kind of like what my friend Steve Sokransky refers to, like, the simple approach to diastology, right? If it looks like overload and it's not obviously an EF problem, then look at the JVP, look at the IVC, see if it's big. But as you can see by her IVC here, it's not impressively big. It doesn't look like it's like big and plethoric. It's got a little bit of collapse. And so I kind of was like, and again, like that feeling where you just kind of want to like just toss the probe, walk out and be like, well, shit, I guess I'll wait to see what else comes back, right? And again, heart failure with preserved ejection fraction kind of came into my mind, but now going over and getting a dimer of 4,900 that had been ordered, Her COVID rapid PCR at this point came back negative, which was nice. Her BNP is certainly up. So it was kind of, you know, again, every time I do a CTPE study, it's like a small part of me, like, especially if I don't really buy into it, like I'm doing it, but I don't totally buy into it, then it's like a little bit of my soul dies. But nonetheless, here we are, we're going to go ahead and do that. And it was funny, the rad who had already interpreted the x-ray as like, this is consistent with, you know, cardiogenic pulmonary edema, at this point is like saying, I thought it was really actually quite polite, like, is there any reason why this couldn't be CHF? Like, you know, why are we still going past with this? And they made comments to the fact that it was most in keeping, you know, it had the right distribution. It didn't look like lymphangenic carcinomatosis or anything like that, although that was listed as a possible differential if we didn't feel like it was related to the heart. Of course, I followed up with her a few days later, which is again, maybe that's why this case was interesting to me, is because it's like, we've been just seeing so many people with runny noses, colds, back pain that won't go away. You know, my family doc won't see me. So, you know, this was actually like, you know, a little more intriguing. So I followed up a little bit, and she ended up responding impressively to Lasix. The internist who had her admitted to the service kind of said, you know, I don't want to anchor here, Paul, but like this looks pretty convincingly. She's improving with this treatment. So we're probably heading that way. And then she had a comprehensive consultative echocardiogram here. And, you know, in fact, it looks like she probably even improved. So I mean, again, if I was better at diastology, maybe I would have been able to kind of identify some of the features, but it looks like maybe even as the volume got taken off, her diastolic function improved, because even here they felt like she only had mild diastolic failure. So there's always so much more to learn, and I'm happy to hear any thoughts about that case, but I'm going to put a big plug in for our upcoming virtual conference for POCUS educators, April 17th. So that's the plan there, and people like Irene and Brian are going to be speaking about how to do POCUS education in your various programs. How's that? How's my timing?
That's a great case, a fantastic case, Paul. We've had a couple cases in the last few years where they've had, you know, very hyperdynamic LVs and pulmonary edema, and they've been found to have MR, of course, right? And that's always one of the caveats with the dynamic ventricle and pulmonary edema is a lot of the blood is going backwards as well as forwards.
Yeah, and again, it's funny because I struggle to integrate. Like I don't use color very often in the ED, and again, it's always that balancing act of moving beyond. And we've talked about this in the past because I had that aortic stenosis case that we discussed many years ago, and it's just about kind of, do I feel like I can reliably and consistently apply this and integrate it in a rational way into my like ED care kind of algorithms, and then always, of course, balancing time at the bedside versus going to see the 10 people who, again, need a primary care physician.
Yeah.
All right, so on that final note, I'll just leave this up like this because it'd be great to have people who use POCUS also teaching POCUS. And you guys, I can probably stop sharing the screen at this point.
Oh, that's great. Thank you for sharing that, Paul. I think I'm really excited, and I think it'll make for some very engaging discussion when we have people in the room talking about education and best practices and what have you. So that's awesome.